Good afternoon, everybody. You say. Good, thanks. I don't know if you're not used to talking to the speakers. You're going to talk to the speaker today. So my name is Eloiza Domingo-Snyder. I'm the Senior Director of Diversity and Deputy Chief Diversity Officer at Johns Hopkins Medicine. So I thank you for having us here today. Came all the way over from Baltimore to your beautiful weather over here. So our first two speakers did a really great job of setting some high-level conversations around what diversity is, what cultural competency is, the importance of inclusion at schools of medicine and at institutions of academic medical centers. What I'm going to talk about today is I'm going to deep dive a little bit into patient-centered care when concordance requests go too far, which my assumption is, as I kind of develop this story today, you'll understand what this is, and you probably have seen this at some of your institutions. But before I do that, I'm going to tell you a quick story. Right up here, this is a picture of a bridge in Choluteca, Honduras. So you can see that on both sides, there's a lot of erosion on one side of the area. And so what happened is Honduras said, we really need this bridge. This bridge didn't exist. And they said, we need to build this bridge because we need to build more commerce and we need to put, some more roads in and things like that, and nobody really wanted to build this bridge. And so in the 1930s, this company in Japan put their hand up and they said, I'm going to build this bridge. We want to build this bridge. And they said, but if we build it, because they were the first Japanese company to do this actually in Latin America, ever, to build a bridge in Latin America. And so they said, but if we do this, we're going to make the best bridge ever. It's not going to go anywhere. It's never going to fall down. And no matter what happens in Honduras, it's not going to go anywhere, right? And so, so they built this bridge, and it's actually called the Bridge of the Rising Sun. It's really beautiful. It did a really, really great job. And even when Hurricane Mitch hit this area, the bridge actually stood. Many of you know that Hurricane Mitch was really powerful, right? And it didn't go nowhere. It actually did good with its promise, but the river moved. So the Bridge of the Rising Sun is now called the Bridge to Nowhere. And they, even though this company said that they were going to, promise this great, thing to the people, they underestimated the power of the wind. And they underestimated something as small as the wind to make a major, major change where they actually became obsolete. So why do I start with this story? The reason why is because if we as institutions of higher learning, academic medical centers don't pay attention to things as small as the wind, then we can become as obsolete as this amazing bridge, right? And so I'm going to throw up a quick case study here. So you have an elderly white male patient who is seen in a primary care clinic for an abnormal heartbeat. A white male doctor enters the room. Accompanying him is a group of residents, including a female resident wearing a hijab. The male patient tells the physician, can she leave? I don't want to be seen by a Muslim. What do you do? Right? So just by show of hands, how many people, have anybody handled a case like this or have seen this or, yeah. So this is actually what we're going to be talking about today and the relevance of what this is. So there's a couple definitions quickly. So patient preference is where a patient requests to be seen or not be seen by a provider of a specific demographic. Some examples here is a black male patient who requests to only be seen by black male providers, a female patient who requests that the nurse who is assigned to her is removed from care, removed from bedside, because she perceives her to be transgender. She says, I think that nurse is transgender and I don't want her to be a part of my care team. Okay, so that's a patient preference that's being made. Patient-provider concordance, which is another topic we'll talk about quickly today, is where the patient demographic matches, so is in concordance with the providers. An example is a female patient who is seen by a female provider. This oftentimes happens in OBGYN, right? So many of us call our OB and we say, I want a female, right, OB, which typically happens. So most provider situations in the United States are actually race disconcordant, which essentially means that the provider's race or the provider's demographics are different than their own. That happens over 84% of the time, actually, in America. I mean, if you think about it, right? So I identify as Filipina, female. I've never had a Filipina physician, never. I've had a Filipina physician for my kids, but I myself, as the patient, I've never had that, and I've been here my whole life, right? And that doesn't mean that we don't have Filipina physicians, right? It means that typically race discordant interactions occur in American healthcare networks. So a bona fide accommodation is where an institution says that whatever is going on in the interaction can be accommodated. I put this up here because I'm going to challenge each of you within your institutional lenses to consider whether or not you do this institutionally for your hospitals or for your schools of medicine. An example is where a hospital accommodates the preference of a female sexual assault victim to be seen only by female medical personnel due to her background, right? So she comes in and she says she's being seen particularly because she's had sexual assault situations occur to her, and typically in those situations we withhold having males care for her, right? Because there may be some PTSD symptoms that occur. Prior to being at Hopkins, I was at Cincinnati Children's Hospital Medical Center. We had a number of kiddos, unfortunately, that came in and were sexually battered, sexually hurt, sexually assaulted. And to avoid PTSD symptoms or to avoid any level of discomfort and to increase the experience for the child, we would really try to avoid having anybody that matched the demographic of their perpetrator, right? So that's a bona fide accommodation, okay? So this is actually a really current issue. In 2012, UCLA law reviewed a number of cases in which individuals were either accommodating for this or were getting in trouble because they were accommodating, right? So a couple examples here, a 2010 case in which there was a resident of a nursing home was asking for only white providers to be part of his care, and the Federal Civil Rights Act prohibited that nursing home from providing all white providers because of just that race-based accommodation, okay? Hurley Medical Center in Flint, Michigan paid out a $65,000 settlement to a nurse after posting a sign, no African American nurse to take care of the baby, outside of a room whose patient's dad had a swastika tattoo, okay? So again, there's a lot of legal risk, there's a lot of risk to the institution, a lot of risk to patient care, and also to your staff. But the thing is that there's actually some pros. I've actually started out by talking about what the cons are. A number of individuals assume that if somebody asks this question, the patient asks for an accommodation, that it's out of a bigoted request. There are actually some pros for why concordance or accommodating a patient preference can actually be a good thing, okay? So some of these pros, and these are we're looking at just some of this literature. There's a lot of literature out there. High patient satisfaction, of course. I mean, I don't know about you, but if I have a Filipina who walks in and is my provider, I'm going to have a pretty high level of attention to her right off the bat. She's going to look like my mom, right? So I'm going to have a level of comfort with her. I'm probably going to tell her stuff that I probably wouldn't tell somebody else, right? Increased quality of communication. This piece of quality communication also goes to quantity. We've actually found in literature that not only does the quality go up, the amount of time that's spent also goes up, okay? Better health outcomes, of course, increased preventative care, impact to health disparities, and greater patient engagement, okay? But then, of course, there are cons. Risk to the organization. Establishing this unsustainable precedent. The fact of the matter is, Johns Hopkins Medicine is in Baltimore. We have a lot of diversity. We have a lot of people who are diverse in our staff. So frankly, we possibly could just logistically accommodate some of this. If somebody says, I just want all female this, or just want black male this, or just want this, there is a logistic that could potentially be met. But in some institutions, this is an unsustainable precedent, right? So for those of you who have had a baby, typically your OBGYN says, I may not be the doctor who's there when you go into labor, right? No matter how much you plan it. I had 2 C-sections, right? And I wanted that doctor at both of my C-sections. Neither of the times she was there, right? And one of them was planned, okay? So you're establishing an unsustainable precedent. There's mistrust issues within the staff and the community. They're showing a wavering commitment to diversity and inclusion. So for example, in your first case, if somebody says, oh, I don't want that Muslim woman here, right? You know, she's covered and she practices Islam, I don't want her. And the doctor turns and says, you need to go ahead and leave, right? All of a sudden, it's like, wait a second, I thought one of our values was diversity and inclusion, and you're making me leave based off of this, right? So there's a question. Also, ethically and morally compromised staff. That student or that staff member who has just been asked to leave, leaves the room and says, what just happened? I thought this was an academic medical center. I thought this was an opportunity for me to learn. I thought this was an opportunity for me to be a part of this and be engaged, right? So what we're challenging you to do today is to consider this for your institution. What does your institution want to do? There is no national precedent frankly, for how to handle this. Many institutions are addressing this right now, and so we're really pushing you to ask yourself, what would my institution do? One example is to create a policy. This responds to changing social and political environments. In many institutions that we've talked to, we've actually seen an uptick in these behaviors from patients over the past 3 to 4 months. Over the past 3 to 4 months, we have had some political changes. And we have had some, and that uptick qualitatively has occurred, and we've seen this kind of testimonially. This creates a standardized procedure across the healthcare system. So it's not like, oh, we would do this here, but we wouldn't do it here. So your institution has a standardized process in order to address this. This tempers patient expectations while also educating them. If a patient comes in and says, oh, I'm going to act like a toddler, I'm just going to ask for anything that I want, and they're going to give it to me, right? Tempers that patient's expectation while also educating them about what the institution, how the institution is going to partner with them, and ensures the patient still receives the best care while also protecting his and her rights as well as the rights and the dignity of your staff, which creates a climate of safety and respect for everybody, okay? So when you're considering, if you are considering creating a patient policy, you'll want to think about clinical and non-clinical settings, which we have primarily been talking about clinical settings. You will also want to think about your non-clinical settings. If somebody comes up to an information desk and your receptionist says, oh, hi, how are you? Or answers the phone or something, and the client says, you know what, you sound black. I really don't want to talk to black people, right? So you're laughing, but it happens. It is happening. Or somebody says, wow, you have an accent, because I don't want to talk to you. Because I can't understand you. I don't want to talk to you. Get somebody else on the phone, okay? Specifically because I don't like your accent or I can't understand you, okay? There's a risk, of course. That you have to consider clinical risk, institutional risk, and staff risk, which we've talked about. Standardizing and integrating education. This I want to pause on because when you educate, you need to educate your staff, your managers in particular, because if somebody at bedside is handling this, your manager or your attending is probably going to step in and assist or back that person up or change the answer or something. Okay, so you need to have some education. Standardized scripts, general culture, communication. Essentially what that means is if you have communication around your institution that essentially shows the diversity and shows what inclusion is and shows the value of all of this, then you're already setting a precedent that bigoted behavior will not be tolerated at our institution. Patients' Bill of Rights. It's also critical to align. And then harmonize systems. The reason I'm putting up here scheduling portals is because if you have a scheduling portal where somebody can come in and preface, oh, I want a black doctor, a male, I want it at this location, and I want him to speak Arabic, and I want him to do this, go. But then then that person comes in to the center and says, oh, but I prefaced a black male this and who speaks this, why can't I have that every single time? It's sending different messages, okay? So your systems will need to be harmonized, looking at credentialing, legal, and ethics. And then the last 2 slides, these are some examples of how patients are coming in and asking for or requesting that a provider be either removed from care or be provided to them all the time. So perceived employee demographics, right? Prior to my saying that I was Filipina, many of you may, well, actually we're in California, so you guys know what Filipinos look like. A lot of people don't know. So many people think that I'm Latina, right? Many people think that I'm half black, half white. Some people don't guess Filipina. So the perceived employee demographic should also be just as protected as what is the real identity of that individual, okay? As I mentioned earlier, somebody who says, oh, that nurse is transgender, right? That happened actually in an institution where the nurse was requested to be removed from care. The nurse was not transgender. She was perceived to be transgender. And so she would still be protected, okay? So the perceived employee demographic for sexual orientation, age, HIV infection, AIDS-related conditions, and veteran status. If somebody was requesting removal of care from that individual because of these situations, or specifically a concordance, an example of an institutional response, that this would be denied from the patient. Accent or articulation, the reason why this would be removed on a case-to-case basis, and many of you may argue this, which is fine, is that in acute and emergency situations, if you don't understand what your provider is saying, or if somebody else isn't understanding, that's a safety situation. So my dad is a doctor from the Philippines. He had a very strong accent when he came here as a surgeon. And so in surgery, he would put a mask on, right? His nurses couldn't read his lips anymore. And that would actually delay care. And they would literally be like, Dr. Domingo, I can't understand you. So he would move his mask up and down. So A, that's a safety situation. She's freaking out here. She's like, no, he did not. But nobody could understand him, right? And so that's a review on a case-to-case basis. Race, ethnicity, national origin, religion, faith. The reason why we put up here post-traumatic stress event, some people say post-traumatic stress disorder. Some legal institutions will say post-traumatic stress disorder because it's tied to a diagnosis. Post-traumatic stress event, I'm a little bit back and forth on this. It would basically mean like if I came in here and I was mugged by a big black guy, and then I went in and my provider was a big black guy, and I would say, oh my gosh, like I really don't want big black guys to be my provider. So I don't have a post-traumatic stress disorder. Something happened to me, and you'll want to think about this, because are you giving license then for your patients to stereotype because of one situation, okay? So again, you'll want to think through that. Gender identity and expression, sex approved for religion and post-traumatic stress events. Okay, so this is just some examples. My last slide, and this is very difficult to read, but the relevance of putting this up here is that you want to think about a branching model for how this occurs. So the patient makes the request. You want to collect the data or record the request, which essentially means in your EMR, your electronic medical records, you want to write down that this occurred. We actually have almost no national data, because what happens is it's operationalized at bedside. Either somebody says, okay, I'll take care of that, or it's like, no, I'm not going to, and then it doesn't make it into Epic or Cerner or your EMR. And then what happens is maybe the patient gets a little bit savvy, and later on down the road, she says, you know what, I really don't want black nurses. And so all of a sudden, she gets accommodated because nobody wrote it down. Okay, so to keep your response consistent and standardized across your institution, some of the other things that you'll want to consider as I close is emergency situations, the capacity of the patient, whether or not the patient has decision-making capacity, if the patient is escalated or not, and these kinds of things. So again, this is just an example of a flow that we work with across institutions as they consider this. Given the political climate and given cross-cultural tensions, unfortunately, there are a number of individuals who feel like they have license to come into our institutions and treat our providers badly. There are pros to accommodating some of these things, and so that's why we say that, but I would really encourage your institutions to consider how you're addressing this in the current political climate and current environment of the United States. Okay? Thanks so much.